So it's interesting. Lipoprotein A is a very interesting biomarker. I mean, it is just like an LDL molecule, but along with certain glycoproteins, also contains the ApoA lipoprotein, which is what gives it its significance, and that makes that molecule very pro-atherogenic and pro-thrombotic. And one of the interesting things about the Indian or the South Asian population is that they develop premature coronary artery disease and what we label as malignant coronary artery disease. As we all know that Indians do develop, cardiovascular disease almost a decade earlier, or have incidence of MI almost a decade earlier. And because of this component of malignant coronary artery disease, and there are a couple of features of this kind of disease where there is extreme severity of the disease, there is extreme prematurity, and there is increased mortality in the young. And another important feature is that these traditional established risk factors, which are modifiable, like diabetes or probably hypertension and smoking, there's a low prevalence actually of these risk factors in malignant coronary artery disease. So there is some genetic component that is underlying this pathophysiology, and lipoprotein A has shown to be a strong predictor of CVD in the young. But I just want to put it out there that the lipoprotein A, it does not drive the treatment in such a way, because it does not it's not altered or modified by any treatment. But one thing is certain, that because it is so genetically linked, just a single measure of LPA in a lifetime is enough to kind of know where the person stands in terms of risk assessment for that patient in primary prevention specifically. So just getting that LPA done just massively changes the approach of how you kind of follow up with the patient, and that is very important for the patient management, and kind of put more focus in terms of the lifestyle modifications that we need to do. So I can kind of say that from different studies, the risk of cardiovascular disease actually increases from the level of 20 milligrams per deciliter for LPA. But just from population studies, I think so a cutoff of 30 is kind of appropriate to see where the risk actually falls and to drive the treatment, if any, in primary prevention. So I guess like anything above 30 is probably what we should look at and kind of put our antennas up for a person, even if traditional risk factors are low for that particular patient, because that signifies that. And another point is about family history of that particular patient. If that patient does have a family history of premature coronary artery disease, I think so it's very prudent to get the lipoprotein A level done for that patient, because that just gives an extra added information whether that patient himself is more prone for developing cardiovascular disease, and we can intervene early in terms of reducing or cutting that risk now. I can speak about basically why we are talking about LPA as a marker for primary prevention. Traditionally in the Indian population, just until recently, primary prevention was not such a big deal, for every household in India. Now people are getting more health conscious in that respect, and this biomarker is so helpful because it has such a strong genetic component. It can actually determine whether that patient is going to develop, and it can give more insights for the patient in terms of bringing about some lifestyle change, give that incentive to make that change and critically change his whole aspect of diet and the approach to smoking or alcohol consumption. So probably it can bring about a behavioral change if there is some kind of an established marker which gives more information than just the traditional risk factors, that way.